Hello, I'm Dr. Burj Wazirian, a prosthodontist at McGill University and private practice in Montreal. On behalf of JCDA Clinical Q&A, I'd like to thank Dr. Strauss for offering this case to review. Upon review of this case, I note the following conditions: high caries rate, missing laterals, partial edentulosum, limited interradicular space between 1113 and 2123, failing mini implants, and defective crowns 1-1 and 2-1 with over-contouring. Regardless of what treatment option is chosen, we need to investigate the etiology and risk factors involved in the caries process. The patient appears to have a high DMFT and active lesions. I would recommend a strict prevention practice be implemented, such as the Featherstone protocol. Because of this, I'd be less apt to recommend full coverage restorations until the situation is controlled. The other consideration is related to the age of the patient. Being a young patient, he will require further dental retreatment in the future, which leads me to favor more conservative treatment options. Bearing in mind the information discussed above, my ideal treatment option for this patient to replace the missing laterals would be orthodontic treatment to create adequate space for implants, new crowns on 2-1 and 1-1, and implant and crown on 1-2 and 2-2. If the patient is reluctant to move forward with orthodontic treatment, my second conservative option would be new crowns on 2-1 and 1-1, a resin-bonded fixed partial denture or RBFPD with cantilever pontics in the 1-2, 2-2 area from 1-3 and 2-3. I would have the following considerations about using this option. We need to ensure there's adequate space for the prosthetic components in occlusion. There is an inadequate amount of enamel on the abutment tooth for enhanced bonding. In this case, there is limited space, especially in the gingival third, but with proper recontouring of 2-1 and 1-1, aesthetically acceptable laterals can be made. There is a 5-year debonding rate of about 20% with resin-bonded prostheses, although debonding is lower with cantilever design. I would also use a pin ledge preparation design on the abutment teeth, however this requires further clinical experience. If the patient does not accept either orthodontics or a resin-bonded FPD, I would recommend a 3-unit fixed partial denture from 1-3 to 1-1 and from 2-3 to 2-1. The major consideration in this option, however, is what appears to be a high caries risk. Recurrent caries accounts for roughly 18% of abutment failure in fixed partial dentures. I would use either a lithium disilicate like Emax material or a zirconia ceramic restoration. With good caries control prior to treatment and use of the Featherstone protocol both during and after treatment, the patient should have an aesthetic long-term result. I'm Dr. Burj Wazirian from Montreal for JCDA Clinical Q&A. Thanks again to Dr. Strauss for offering a case to review and for everyone who participates in the discussion.